Uh, so, I have been asked to conduct a panel discussion on the management of pleural effusion. And when I first saw it, my first reactions, at that time was, that's easy, man. I mean, it's pleural effusion. I mean, I do it for a living, actually. My subsequent reactions after listening to the previous speakers and, answering what Dr. Rajiv Goel was asked to, was the more I learned, that the more I realize how much I don't know. And the more I talk to Dr. Rajiv Goel, I realize that I don't know much, actually. But that's the privilege of working with Dr. Rajiv Goel and Dr. Abhishek Bansal, Dr. Chaturvedi, and uh, I actually feel that thoracic tumor boards, we have one every Thursday. I have learned more about the management of pleural effusions and stentings in those sessions than I actually learned during my DM. So thank you for the MDT support that I actually get over there. Now coming on to, because we are running short of time, and let me ask one very basic question to all my panelists, and I'll start with Dr. Vanita. Dr. Vanita at Tata, who manages the pleural effusion in your setup? I'm sure it is not a medical oncologist. Is it a surgical oncologist? You have an interventional pulmonologist, you have an IR, or any other person?
Ullas, so in our setup, again, it's a multidisciplinary management, and it involves the surgical oncologist, the pulmonologist, and the interventional radiologist.
So who is your first go-to man? Who is your first go-to man or a woman? Dr. Sabita is also there.
So I guess there isn't any first go-to person really. We have actually started a clinic with our pulmonologist. So we evaluate, especially all of these difficult to manage pleural effusions or other pulmonary disorders. So we look at the scans together, and then we decide, is this person best suited for a pigtail? Is this person best suited for an ICD or something else? And based on that, we decide. So there isn't only one specific specialty.
I am 100% sure, Dr. Vanita, you should definitely stand for the assembly elections in Maharashtra next year with a kind of absolutely politically correct answer that you give me all the time. I am not going to ask Dr. Darlong and Dr. Abhay Kapoor and Dr. Rajiv Goel at Rajiv Gandhi because it's an MDT meeting. We're going to get the same answers. Dr. Nikhil Bansal at Fortis.
Yes, sir.
Yeah, hi. So you are the surgeon. So is it
sir,
guy?
Sir, I'm an intervention radiologist.
Okay.
Yes, sir. So it's basically depends on the case, whether the patient having a generalized free fluid or whether it is a loculated effusion, whether the patient having a more than 1 mm size septation. So if the patient having a more than mm size septation or it is a dense one, we send the patient to the oncosurgery team or the pulmonologist for the thoracoscopy. Otherwise, in majority of the cases, either we or our palliative medicine team, they do the
honors.
Yes, sir. Yes, sir.
So, Dr. Nipun?
Yes, sir, Doctor.
Good evening, sir. A very good evening,
hi, Dr. Nipun. So who's the captain of the ship there?
Sir, I am from the same institute, Mahatma Gandhi Institute, as Dr. Nikhil Bansal is there. And we follow the same protocol as he just told us, sir.
Fantastic. Let's just move around over there. Most of the time, I think all the big institutes are getting the the MDT teams, and that is very, very important. Let me again come to you, Dr. Nipun, once. Out of the last 100 patients of pleural effusions that you have seen, how many, just a ballpark figure? I'll ask you this question, then I'll ask Dr. Rajiv Goel this question, and then I'll ask Vanita this question. Or maybe I can take it to Dr. Pavan Kumar. How many people in the last 100 pleural effusion patients have got a tapping, have got a pigtail, medical thoracoscopy, an IPC, or a decortication? Just a ballpark figure.
Sir, I think Dr. Nikhil will be a better candidate to answer this
Dr.
question.
Nikhil, what is your
experience? I agree with our panelists. Majority of the patients go for USG guided tapping. Few of them who require pleurodesis depends on ultimately the final decision depends on multiple factors. Whether you have loculated effusion, trap lung, IPC versus tube, all depends on that. So more than 60% definitely USG guided tapping, followed by a chest tube, and then further pleurodesis depending on the pathology. Few of them undiagnosed pleural effusion come to me for medical thoracoscopy, and tunnel pleural catheters are very few.
So
I agree with 5%, Prabhakar.
How many medical thoracoscopies and how many tunnel catheters in the last, let's say, 1 year?
So our cytology department is very strong, and I get diagnosis most of the times in cytology. So medical thoracoscopy, advanced, if they want to run molecular markers and the IHCs and all those, they need more tissue. So about 5 to 10% of patients, most from the breast cancer and lung cancer, come to us. Other than that, tunnel catheters, I agree with 5% and less than that.
Okay, let me come to Dr. Rajiv Goyal. Dr. Rajiv Goyal, so you spoke a lot about the tunnel catheters and medical thoracoscopies. So what is the situation at RGCI where we work?
Yeah, see, I think if you put the whole thing in perspective, virtually all the patients get tapping at least once. Right? Now, having done that initial tapping, depending on whether you are dealing with a patient who has undiagnosed pleural effusion, if he has an undiagnosed pleural effusion, if he doesn't have an obvious mass on the CT or a nodule on the CT, he goes for medical thoracoscopy, which would mean about 5 to 10% of the cases. Most of the patients are who would get either on cytology or because of other reasons the thoracoscopy is, for example, not possible.
What about the tunnel catheter versus the pigtail, sir?
Yeah, so having said that, next the thing comes to what you are going to do in terms of treating the patient. So there the situation is that I think what we are basically doing in Rajiv Gandhi is that we have found that the tunnel pleural catheter can be put for a large number of patients. However, the situation in India is such that you have to be very sure that the tunnel catheter will be taken care of at home. So my take on this is, and I think that should be the take for all of us, is that if the patient is able to look after the catheter at home, which means that there is a caregiver at home who can help in drainage of the catheter and make sure that the catheter is not going to get infected. That is the patient who may be offered a tunnel catheter. We have also looked at the cost of tunnel catheter versus the pigtail drainage. We find that the cost is almost the same because 4 or 5 days of stay in the hospital versus the 30,000 rupees tunnel catheter, the cost remains the same. However, in those patients where there is a trapped lung, then tunnel catheter becomes a good idea. Where there is not a trapped lung, then you may offer either a pigtail catheter with pleurodesis, one go, like Abhishek said, or if he opts for going home early, then he can have a tunnel catheter with autopleurodesis taking place or a talc pleurodesis later on. Very few cases we are referring to Dr. Darlong, who's here also, for decortication, but I would tell you that there are those certain subset of patients who got a good performance status, who are doing well otherwise, who have a loculation which needs decortication, and in those situations, it is worthwhile to keep in mind that these patients all do not have a completely dismal prognosis. They should be also a surgical operation should be sought in those few cases where the patient may benefit from a decortication. I hope that answers the question.
Ullas, can I come in for a minute?
Yeah, definitely, sir.
Yeah. You see, I think Dr. Rajiv very nicely he summarized, but I think one or two things we must remember and must be very careful. One thing is not all pleural effusion because of malignancy will need a intercostal tube drainage. I think that has already been discussed. But again, one more precaution, very specific precaution was to be taken is that whenever you are deciding to put in a intercostal tube drainage or a pigtail drainage, then you see that there is no proximal obstruction. Otherwise, you will be stuck. The lung will not expand and you will end up with putting the tube, and I think that has already been told. But these one or two precautions one has to take and keep in mind.
Fair enough, sir. Yeah, thank you, sir. Dr. Darlong, I actually don't envy the thoracic surgeons. In stage 1, you have a radiation oncologist giving SBRT. You have a IR person giving RFA. In stage 3, whether you used to do mediastinoscopy, you have now EBUS people coming up over there. In trapped lung, now decortication is there. So, Dr. Darlong, are we reducing? And I just saw Dr. Ramakant Deshpande also was there. So, what is the experience been for decortication for trapped lung actually? And how many procedures? How good? How bad? Is it really something to be even thought about?
Okay, Ullas, I was really waiting for your question. And I would first begin with saying that lung cancer stage 4 American oncologists are talking about a lot of target therapies, the good behaviors, the PD-L1, immunotherapy, all these things. So I will take it at a different level. Most of these effusions can be managed with a catheter, the Pigtail catheter, most of the times. It is those few cases wherein you got loculation, secondary infection, and lung is trapped. So these are cases wherein basically a thoracic surgeon needs to come in. And decortication is not specifically very much indicated in CA lung because the whole lung is plastered with a disease. So you cannot go and basically re-expand the lung. I will go more aggressive one step ahead. And I will say that in such cases, when you got empyema, a pleural window definitely makes sense because it is one-time procedure. You are basically eliminating the source of infection. And the patient goes on to have his her chemotherapy, immunotherapy, target therapy. And we don't have too much of experience in doing pleural window because acceptance is low. It is basically those very fit patients which you have referred that we have done on them, maybe about 2 or 3 of them. And they are still basically on chemotherapy and they are tolerating the chemotherapies and immunotherapies. They are still surviving with the disease. And so I think definitely we need to explore more of this surgical procedure, not decortication mainly. Decortication is useful mainly for other malignancies wherein you have got a pleural effusion because of that malignant effusion and it's trapping the lung.
Okay. Let me now
go on. Pleural window is something we need to consider for fit patients wherein you can basically control the local site of infection and then you can continue the other therapies.
Okay. Dr. Vanita, can I get you in on this? Let's say you spoke about you have an MDT meeting and where you discuss over there. Now let me ask you a question. Let's say a patient comes to you with cough with breathlessness grade 2 on X-ray has a moderate pleural effusion. How do you decide for the benefit of all the 150 people who have joined over here whether you want to go ahead with a single time aspiration versus how do you want to get a drain put? What are the factors? Does it depend upon the strategy depending on the type of cancer? Does it depend upon the wild type versus biomarker driven lung cancer? How do you take a call? Clinical.
So this is a patient who is not diagnosed a case of malignancy. So I guess initially, the first question is it a diagnostic or is it a therapeutic tap? So if you don't have a diagnosis, then clearly you will just do a needle aspiration and send all the diagnostic workup. If you already have a diagnosis of cancer, then all of these factors come into play. So how symptomatic is the patient? I mean, the reason for managing the pleural effusion is the symptomatology and the quality of life of the patient. So how symptomatic is the patient? What do you expect the response to chemotherapy or targeted therapy to be? And so all of those play into your management decision process. So by and large, it's first time it is needle aspiration, just a small volume or a large volume, depending on the symptomatology. And then based on all of these factors, we make the next decision.
A very important question, Dr. Rajiv, I would like to ask you is, sir, when you are sending a single time aspiration, let me ask Dr. Abhay Kapoor. Dr. Abhay Kapoor is an interventional radiologist at Rajiv Gandhi. So when you are sending a single time aspiration with the ultrasound guided, what is the volume of fluid? This is for the benefit, we all say cell block. Now, do you send the entire 500 ml? Do you send 50 ml? Do you send 1 liter? How much do you send? Dr. Abhay.
Normally, if a patient is sent for a single time aspiration, the first question which comes to mind is it only diagnostic or is it therapeutic? So if it is diagnostic, I will aspirate only 100 ml using the 22 gauge needle, the least invasive for the patient. But if it is going to be therapeutic, so we put in the cannula and whatever amount, if I've taken out a 1 liter, but I will still send only 100 ml to the lab, which as per a lot of studies is sufficient enough to diagnose any malignant cytology if it is the malignant cells are already existing.
So Dr. Rajiv, do you agree with that? The more the better or 100 ml is good enough, sir?
No, 100 ml is good enough, and that is usually it will tell you clearly whether you have got enough, whether there are malignant cells or not. That is enough to tell.
Okay, so now let me come, because we're already late. Let me come to the meat of the matter. Now, let us say you have a patient who has been diagnosed with non-small cell lung cancer. The patient requires he or she has undergone a therapeutic aspiration twice or thrice, requires repeated tappings. how do you decide? Now, again, this is a very basic question for the medical oncologist. How do you decide between Pigtail versus IPC? Let me ask Dr. Pawan Kumar first, and then I'll take Dr. Rajiv Garan, because you've heard his opinion. Dr. Pawan Kumar.
Yes, sir. So, Dr. Batra, the effusion management depends on multiple factors. Whether you have free-flowing effusion, you have a loculated effusion, or you have a trap lung. Means you have endobronchial obstruction and lung is not going to expand, or there is interstitial lung disease simultaneously.
So you do not have in this particular, let us start the simple. You do not have an endobronchial obstruction. The trachea is shifted to the other side. So let's see how you approach that. Between Pigtail versus IPC. Let's say it's a PG student who is listening to this, sir.
So you drain the fluid. You relieve the symptom with a complete drainage of the fluid. Or intermittent drainage of the fluid to avoid the re-expansion pulmonary demand. The catheter can be used as a Pigtail or an intercostal drain, whatever you have available in the institute and what your patient is going to afford, what expertise you have. If you have a PG student who is trained in intercostal tube drainage, you put an intercostal tube drainage, which can be 16, 20 French or 24 French. A Pigtail available, patient is affordable, you have expertise to put, you have ultrasound guidance, put a Pigtail. Ultimate aim is to drain the fluid. So first will be a Pigtail catheter. IPC doesn't come first during my experience as well as during the post-graduation training as well, because most of patients are not affordable for that. But if you ask Pigtail versus IPC in a massive pleural effusion, anything is good for drainage of the fluid. First choice is always a catheter, Pigtail or ICD.
Okay, Dr. Rajiv. So let's put Dr. Goyal. Let's keep the money out of it. And you also came to you also took an analysis where you said money was not really an issue. How do you decide, sir, when I refer a patient to you about, how do you decide between, we had a discussion around a month back. How do you, in your practice, decide between ICD versus an IPC catheter, sir?
Yeah, so I think we already said and talked about that in the previous sort of few minutes, but basically I'll just reiterate the point that if you have a patient who doesn't have a trapped lung, and in which you need to drain the fluid, what we normally are doing now is to give them the option of two kinds of drainage procedures. One, which is going to mean that he has to stay in the hospital for 3 to 5 days, during which the fluid will be drained out through a Pigtail catheter. And once that is done and the lung re-expands, we will do a pleurodesis and come out and hopefully get the catheter out. So that is one way of doing it. The other way is that an indwelling pleural catheter can be put where the fluid will be drained out as much as is possible in one go. After that, the patient can be discharged maybe the same day or the next day. And after that, the patient will be taught how to do the drainage himself at home every second day or every third day. And then he comes back to us after a week or 10 days, after which if the fluid has, drained out completely and there's not much of fluid draining out, then you can go for a talc pleurodesis. Or if the patient is, still draining fluid, then he continues to do a self drainage at home and then comes back to you again after a week or 2 weeks. And then we may follow suit, like I said.
So can I just, so Dr. Rajiv, okay, go ahead, sir.
Now just let me finish. So basically these two options are given. We also look at the educative, the level of education of the patient and his caregivers. If the patient's caregivers are such that they understand how the pleural fluid is to be drained, we get one of the caregivers in the OT itself, show him how the procedure is, the drainage procedure is done. Same day, next day before going, again, we make sure that he understands how it is done. The need for sterility while, the aspiration drainage is done at home. And if he has any issues, we give him our number and we have his number so that we can be on constant, communication with him so that in case at any time he has a problem. See, the difference between the West and here is in the West, they have these, nurses who go to the patient's home who will, help out with the drainage and, help them to understand how it's done. While here we have no such support. So we have to be very, very sure that the patient should be able to manage the catheter at home with his caregiver. And then if that is so, then we say, okay, you can go with the IPC if you would want to, be discharged quickly. So that is how we do it.
Sure, sir. Can I take Dr. Vanita's comment on this? Dr. Vanita, what proportion of your patients are undergoing ICD versus IPC?
So
just a ballpark.
IPC almost hardly any. So by and large, it would be ICD or a pigtail. So the tunneled, you're talking about the tunneled
the tunneled one, yes.
Yeah,
so what is
hardly,
it that is
hardly
prohibiting us from putting a tunnel catheter in your setup? Cost. Okay. In fact, there are two comments to which that I will like to make. I had that discussion with Dr. Rajiv Goyal, and the comment which I got from it is not the financial status of the patient which is important in deciding between IPC and tunnel. It is the mental status of the attendants which is more important in deciding, they should be able to take care of the infection. That was the first thing he said. And the second thing, Dr. Rajiv, sir, I have a comment on that is, it is easy to give numbers, but who will pick up their phone? That is the only thing. They can keep on calling.
Ullas, sir. Other than the cost of the catheter, those bottles also are expensive. Those vacuum bottles, which have to be replaced, on an ongoing basis. So that's very, very difficult for our patients.
Dr. Vanita, let me just say that yes, problem has been sorted out. That those bottles are no more required. Both the Pleurex people as well as the Rocket Fusion people are giving, detachable sort of valves with the catheters. So you don't need those disposable bottles anymore. And so that cost has been taken out of the, out of the equation. And so you can just drain it with a 3-way, sort of syringe. And that is not a problem anymore. So if that is a problem, don't, figure that into your calculations, because that is no more an issue.
I didn't know this, sir. Thank you. This is really good information.
I think Ullas, the issue is that with the IPC, it's a labor-intensive thing, both for the patient and for you. So you have to be ready to be able to give that kind of service if you are going to put the IPC. Putting the IPC is not the problem. Anybody who can learn, put the IPC, but then he should be able to give that kind of service and support to the patient that, yes, if you have a problem, I am there to, take care of it. And that is true for all IP procedures, whether it is stenting, whether it is something you are married to the patient and you have to, sort of nibhao that marriage.
Sir, ये marriage वाली बात यहाँ मत करो. I'll start with my jokes and it will be difficult over there, sir. So we will talk about that later, sir. So Meenu is also listening, sir. So I will not talk about marriage over here, sir. There's a small question over here, sir. How much fluid should be drained? Dr. Abhay, maximum fluid in cases of a unilateral effusion, in case of bilateral effusion.
We can drain 1 liter easily in case it is unilateral, and in case most of the malignant effusion, if it is bilateral, you can drain 1 liter from each side. The only fear is of the pulmonary edema, and each side works separately. So you do not need to be scared about it. You can drain 1 liter on each side.
Okay. Dr. Gururonak, hi. He is asking any views on pigtail with a valved urobag for a OPD-based management. Dr. Rajiv Goyal, if you can take this one.
You can use a Eurobag. The problem with the Eurobag is that it's very difficult to make out, things like air leak and things like, if there is if the column is moving or not. So which is why we don't use Eurobags. You can use a Eurobag because it acts like a Heimlich valve, kind of. So air will not get in. But that is why we don't use Eurobag, because you can't see column movement properly and you can't, appreciate any air leak properly.
Okay. Sir, I've got some more doubts. So let me start asking some more doubts. Okay, here we go. Can I ask Dr. Nikhil Bansal this, and then we'll go to Dr. Pavan Kumar.
Yes,
rapid pleurodesis or delayed pleurodesis? Any rule of negative suction? I still remember sometimes back we had a huge that 3-wala machine which was connected to the patient for expanding the lung. Are we still doing it? And what about the rapid or the delayed pleurodesis?
Sir, I don't have much experience about this particular thing, sir.
Okay, Dr. Pavan.
So rapid pleurodesis was delayed in the sense you do the thoracoscopy and immediately do the pleurodesis.
Yes,
this is the question. So yes, if we send the frozen, we get the diagnosis, we get multiple tissue samples. So the tissue is never inadequate for us. We get multiple sample, and you can consider the pleurodesis in the same setting. Delayed pleurodesis in the sense the traditional approach that you don't have the fluid drainage for last 3 days, 50 ml or 150 ml for less than 3 days, and you can consider for a pleurodesis. It depends on the kind of situation. It is individualized ultimately. Second question is any role of negative suction. Previously, we used to use that. Even after pleurodesis, we sometimes used to put a negative suction after 1 hour of pleurodesis and declamping the tube. But no major added benefit we have seen when the lung is going to expand completely. And even in thoracoscope, you can gauge that. When you put a negative suction with your with the thoracoscope, you can see the lung coming up. So most of times, negative suction is not required.
Okay, so Dr. Rajiv, I think your just two brief line comments about rapid or delayed pleurolysis. The first question.
So rapid pleurodesis basically means that you don't wait for the fluid to diminish before taking the tube out. And I think there was a reference to that in one of Abhishek's slides, where he showed that there is a paper showing that it works as well. You don't get too much out of waiting too long. So you may take the tube out earlier. You don't really have to wait for the fluid to go down a lot. People who have got very high turnovers of fluid, people who are bringing out 500, 700, 800 ml of fluid. In those patients also, if you do a pleurodesis, negative suction helps because immediately after the pleurodesis, after you put the sclerosant inside, if you put the negative suction immediately after that, then you are bringing the pleural surfaces together. And thereby you may, improve your chances of, getting a better pleurodesis, because otherwise the turnover of the fluid is so much that it will, keep these surfaces apart and not allow the pleurodesis to occur.
So my question over here, Dr. Rajiv, to you at that time is, and that is my problem with the rapid pleurodesis, that you don't know what is the turnover of the fluid going to be on day 0 when you do a insertion. If you do a pleurodesis at that time, aren't you more likely to fail the pleurodesis?
So that's why we don't do it on day 0. No?
Yeah, we don't do.
You put in the tube and then you wait at least for 24 hours to see whether the lung is completely expanded or not.
Okay. So Dr. Vanita, I think we have answered the TAC. I think everybody's favorite is TAC, and we don't use Johnson's baby powder anymore. Steroids and pleurodesis, I think we will take this both together.
Sorry, Ullas, I'll just jump in there. So we are actually currently not using TAC. I think the TAC, we were having quite a bit of problems with infections. And Steritalc is available, but Steritalc is a bit expensive for our patients. So currently we are using Bleo in our hospital.
Okay, fantastic. So, I mean, are you having a trial or
no,
are you going to
no,
compare?
No.
Okay.
No. Just routine care.
And Bleo is, the dose of Bleo is 30?
Oh, I don't know. Yeah, that's the surgeon's foot. I don't know.
Fair enough, ma'am. So, ma'am, let's say the chemo and pleurodesis. So, let's say the lung has expanded, and my major problem. Let Dr. Rajiv and me put it out in the open is, they don't want us to give steroids. And how can you give chemo without steroids? So how do you, learning from you, Dr. Vanita, or how do you manage that?
So I think the question of the steroids and pleurodesis is just right at the time of pleurodesis. I don't think it's a blanket contraindication as far as I know. I actually have not given it a whole lot of thought since this until this meeting, this was really a good meeting, and I learned a lot. But I will take inputs from Dr. Rajiv and all of you. I don't know, we just give it routinely.
I know, because the moment, so I'll tell you what happened was we had some 3-4 pleurodesis failure. We blamed them, they blamed us. So, then we said, okay, fine. Then after that, we decided we blamed steroids for that. So Dr. Rajiv, I'll tell you what I do. First your comments, and then I'll tell you what I do.
So basically, I think what you do is you time your procedure, properly, which means that I will either do the pleurodesis and then wait for a couple of days before you give the chemo, or you will give the chemotherapy and wait for a couple of days and then do the pleurodesis. So basically, it's a question of timing. You need to give about 48 hours before the Dexona is given, and or after the Dexona is being given, to allow the pleurodesis to be effective. So that is what we are doing, and I think that is the appropriate way of going about it. So you need to be in sync with your medical oncologist in terms of when you want to time your pleurodesis.
Fair enough.
Ullas, if I can comment for a minute, I think I don't know what is the view of Dr. Rajiv about chemical pleurodesis with the other agents. Obviously, talc pleurodesis is the best. What about Povidone Iodine? Because that is what PGI routinely does it.
Yeah, so I think people also, so I think they've gone to talc now, because basically the thing is that Povidone Iodine, the results are not as good as talc.
Yeah.
So basically you can use Povidone, and I think we talked about this question before you came in, that there was this question about Povidone Iodine, and The answer is that the results are not as good, but it's still a good alternative in those situations where the patient can't afford it. And the other advantage of povidone iodine is that other than iodine sensitivity, there are no other major reactions with it. You can reuse it if necessary in a case where who has failed once. So we used a lot of povidone iodine before talc came in, but now we are using talc.
Yeah.
Okay, sir, I think, thank you. So we are slightly late. And this is to Dr. Nikhil Bansal and then to Dr. Abhay Kapoor. Non-expanded lungs after catheter placement. Let's say you have put an ICD or something and the lung is not expanding. What do? The medical oncologist is obviously going to blame you. The patients are going to look at you with those eyes, that usi ke baad sab kuch kharab hua hai. So how do you manage that? The lung is not expanding.
I think we usually refer those patients to the pulmonologist.
That's okay. Dr. Pavan Kumar.
So actually, we need to. Yes.
Actually, there's a limit.
Dr. Abhay first and then Dr. Pavan. Dr. Abhay first.
So you can drain only up to 1 liter in a day. And if that's the amount that you're getting and the production is higher or the lung is not expanding for whatever other reasons, the interventional radiologist actually will not be able to add on much to this. All that catheters can do is drain the fluid out. But if still the lung is not expanding, then I'm sure Dr. Rajiv Goyal is going to come into play.
Okay, Dr. Pavan and Dr. Rajiv Goyal is having a smile of his life. All roads lead to Rome. All roads lead to Dr. Rajiv Goyal. Dr. Pavan first.
So, when we start deciding our management of pleural effusion, you look at the X-ray. Your mediastinum is central. You have a moderate or massive effusion. You know that there is something which is holding the lung central. So there is either endobronchial lesion or there is something in the lung which is not allowing it to expand or displace the mediastinum to one side, the opposite side. So that gives you a clue that there is something else is happening. You have a CT scan or contrast CT done and it will tell you about something about endoluminal component for sure. Then you go for a diagnostic or a therapeutic pleural aspiration and you see during that time your lung is expanded or not. So if lung partially expands or even if you have leftover of about 500, 600 ml moderate pleural effusion, that is the time you decide about this is going to expand further. I need to do another imaging to look for. Ultrasound also helps during that time. So multiple factors play in place. If suppose there is a good response to the chemotherapy is going to be expected for the primary tumor, then we wait for the chemo to kick in and then see whether the lung expands or not. If there is an endobronchial thing which is holding the lung, trapping the lung, then you have an option of releasing the endobronchial obstruction and letting the lung expand and then further consider. Ultimately, if the lung doesn't expand, the fluid fills, patient is symptomatic, it comes to the ambulatory pleural fluid drainage versus IPC versus the chest tube, whatever is available.
Yeah, true that. So, very importantly, look at the medius and
Ullas,
yes,
Ullas.
Dr. Dalong.
Yeah, I think I need to come
you
in
were
here.
Also there. Sorry,
these are the cases wherein you basically need a thoracic surgeon. These are the particular cases wherein there is a role for decortication, though very limited, if it is basically trapping the disease is trapping the lung, not because of the fluid, the collagen, the fibrinous layer. In that case, decortication is not possible, but it is empyema. So these are cases where in the pleural window, you do a diagnostic thoracoscopy, you see that the lung is trapped, you can do a decortication. In some cases, not all. If the disease is on the pleura, then in that case, you can't do a decortication. So if there's a collection, in that case, you can make a pleural window. So this is basically like the treatment done for empyemas previously, and mainly in tuberculosis. This can be applied in such select cases, which I said we had done in few cases. So these are, I think, the cases wherein you need to really see, the role of thoracic surgeon when everything has failed. This is exactly where we come in and intervene.
You are my savior. You all are my saviors. I will.
Can I ask one thing, Ullas?
Yeah, yes, Dr. Vanita. You're asking or you are pulling my leg?
No. I'm genuinely asking. Have you all ever done decortication for these trapped lung? Because we see it, and the patients are really quite miserable. But normally we just put we remove the tube and put a colostomy bag or something and continue on. So, do you all ever do any surgical procedures?
Dr. Dalong?
Yes, we do, Dr. Vanita. We do. These are cases who come in, not many of them. It's a few select cases, basically good performance status, well motivated. And we are doing surgery. It's not invasive, like it's a thoracoscopy. And it is done under single lumen. We don't use the double lumen tube in such cases. And we just put in a scope, see if a decortication is possible. And we can be done using a single port, uniportal we call it nowadays. And if it's not possible to re-expand the lung because of the disease process overlying the pleura, in that when we excise the rib, about 2 ribs, and make a window. And so we don't let the collections drain inside. The infection focus is taken care, and the chemotherapy or any systemic treatment continues with that.
Dr. Darlong, if I give you more time, you will in fact do the pleural window itself right now. So just wait. Let me ask Dr. Rajiv Gandhi. This is going to be my last question probably because we're already 20 minutes late. Sir, the third question for you. The second and third. How do you manage pleurodesis failure and how do you deal with multiple loculations?
I think Dr. Darlong sort of wants to go for his dinner quickly, so he thought of preempting got on to decortication. But just before the decortication part comes in the role of adenolysis. So you can use streptokinase. We've been using it quite frequently, although there have been doubts raised about allergic reactions and all, but we have not really encountered it. But streptokinase can be used to lyse the fibrinous adhesions many a times, and it works very well in malignant pleural effusion. There are several papers which have been which show the evidence, and we have found that in those cases where the tube stops draining for some reason, lung doesn't seem to expand.
Just I'll talk to you.
And then you may consider, putting streptokinase 250,000 units every 12 hours for 2 to 3 days, and that many a times will facilitate the drainage, and many a times the lung will expand. So that is one more thing that can be done before you consider a surgical option. And so that is the answer to your question.
Okay, I think that was it, and we are 20 minutes late. I could have actually gone ahead with this for half an hour more because I've got so many doubts regarding pleural effusion. But just to conclude, I think I started off with saying the more I learn, more I talk to people, the more I have doubts. But I think I will end by concluding the more I learn is the more I learn that I have more to learn. So I think it was a fantastic session by the Indian Academy of Lung Sciences involving the IP people, the IR people, the surgeons, because, it's very important that we understand each other. And this was a true MDD meeting. And I would like again to say that the teamwork is a success basically. And thank you everyone for helping me actually grow and learn. I knew we will learn a lot, so I already put this slide over there. Thank you.